Right, and of course that story by Helen Aura also, and the story there that preceded that of Universal Molo, acts as a segue to our discussion this morning. Today, we turn our focus on streamlining the universal healthcare in the country. What are some of the challenges, of course, on the road to realizing a universal healthcare in the country, a universal health coverage in the country as well. Allow me to introduce our guests already who are in the studio with us to take us through this particular discussion that we'll be having this morning. I'm holding court this morning with Lydia Macharia, Director, Employee Benefits, Kenya. Also, we do have with us Dr. Amit Thakkar, who's the chairman of the Kenya Health Federation, also the founder of Avenue Health Center. We do have with us as well Dr. Andrew Mulwa, who is a CAC from Makueni County Health, and also we do have with us Professor Dominic Mwenje, who is the CEO of Maternal Hospital, and I'm holding court this morning with Dr. Onyango, who is a knowledge translation scientist from African Institute for Development Policy. And we want to hear from you this morning as well. What are your thoughts as far as realizing universal healthcare in the country is concerned? Of course, we know this is part of the Big Four agenda that the President pronounced last year. And of course, also this is domiciled in the Vision 2030 as well. Policy papers have been out on how we can actually get to achieve universal health coverage in the country. But still, there's so many kinks, there's so many wrinkles that we need to iron out. And that's why we have this discussion today. We want to hear from you. This is, of course, affecting you directly. Yesterday, we saw how also exorbitant prices or, of course, medical access when it comes to maternity, how also, maternity fee is skyrocketing, going way through the roof as well. So we want you also to head over to our Twitter handle, which is AMLiveNTV. AMLiveNTV is a profile name on Facebook, and 20505 is our SMS portal as well. Let's just begin from that particular story. The translation, the Cuban doctor here in the country, but of course also many of you don't know Spanish. Many of you also, or many people also within maybe the communities in the villages there, they don't really speak fluent English. So how does that also augur for the people who want to be treated? Will there be a delay, the translation? Helen was telling us many of the symptoms also, or misdiagnosis can really occur along the way. Let's just begin smack dab in the middle, because I know Dr. Andrew Mulwa is here. He can tell us more about this particular incident of the Cuban doctors. Are they in your county? I think you've set the stage nicely for them, so they have good facilities as well with the runaway, of course, success that you do have as far as universal healthcare is concerned. Good morning.
Good morning. Thank you very much. I think the issue of Cuban doctors, first to us as county governments, is welcome.
Yes.
Because they bring in specialties that under normal circumstances in the Kenyan market,
yes,
we would not easily get. Particular example is Makueni, where I come from. We have had this ICU equipment that we did a year ago, and have been trying to get a critical care specialist from the market,
yes,
and have not been able to get. Counties like Mandera, Wajir, Turkana have been trying to, Samburu have been trying to get surgeons to run theaters in those counties, and they could not get for a long, long time.
Yes.
Despite many advertisements, many incentives. But now with the Cuban doctors, they already have those specialists in the counties. And I think from my own perspective, because we interacted with these doctors at their induction at Kenya School of Government, and all of them are English speaking. And we feel, yes, like you say, there may be challenges in terms of accent, in terms of understanding their English, how they speak their English, and how our Kenyans speak their English. But we must also remember that literacy levels in this country are well above 80%. And therefore, just a small population of Kenya,
yes,
are not able to communicate in English. Then secondly, these are specialists. They are not primary caregivers. So they are not the first line doctors.
Okay.
By the time you get to a specialist, you have been seen probably by a clinical officer, you've been seen by a medical officer, and therefore the issue of language because you are not the primary person who is seeing the patient for the first time. There will always be another clinician who has seen this patient before they get to the Cuban doctor, because they are specialists and not primary caregivers. And therefore, the issue of language, to me, is barrier is not a huge challenge. Again, if there are circumstances where there is a total barrier in terms of communication, there is room for interpreters within the system. But from the experience that I'm getting from Makueni, and having interacted with the Cubans at the Kenyan School of Government,
yes,
all of them are able to speak English. And therefore, I don't think language is a big challenge. And we need to look at the positives that they bring in. In terms of specialities that we could not get in the counties, Bomet today has an endocrinologist, which is something that in our wildest imaginations, we would not have imagined that they would have this year. Today, Wajir as a radiologist, in our weirdest imaginations, we would not imagine Wajir would have a radiologist in 2018. So this, to me, and we should also not forget that this comes as also an exchange program, that some 50 Kenyan doctors will go to Cuba and train and come back with those skills that these Cuban doctors bring.
Thank you.
And therefore, to me, I think the positives outweigh any challenges that we're facing.
Right. Dr. Amit?
Yeah, Debarl, I think this is a good debate, and it actually gives us an example of what's going on in the health system.
Yes.
We have a stakeholder engagement crisis. The deal is so good that even the private sector could have engaged with the government to go ahead and bring in more Cuban doctors. But it's totally mismanaged by the government, and they must learn from this. The poor mismanagement of how we dealt with the Cuban doctors is the reason why the unions, the doctor associations, and the industry is wondering what's going on. It's all shrouded in mystery. I learned today from Andrew that actually they're getting 100,000 shillings as salary in their pocket, and they're getting another 350,000 shillings being sent to the country. So we're getting an economic deal that's far too good. All the counties have to do is to give them a furnished house, and they get 2 specialists without dipping into the county budget. It's a great deal. How come all this was not being shared openly with the industry? This is why the media has taken the Cuban doctors up as an issue and has given so much airtime, and yet it should have a positive spin. So I think what the ministry and the government should do quickly in the health system is engage with the stakeholders effectively. We're going to face the same problem with UHC, right? Because of lack of clarity and lack of engaging the stakeholders effectively, we might end up in a confused state in a nation where we have a desire to provide affordable healthcare for all, but we end up in a complete disarray. So it's a good lesson.
It's a good lesson. Right. It really acts as a segue also to our story on this as well. Good lesson. Let's hear from also Dr. Bernard Onyango, because you also did a baseline survey on, the access to universal healthcare. You're calling it the rapid evidence synthesis. This is from the African Institute for Development Policy. What are you finding so far, so that you can actually lay it down and we can actually thrash it or broach that particular subject broadly?
Yeah, so I think there was a couple of years ago, so maybe two years ago, thereabouts. And in our rapid synthesis, I think our findings, which speak to what Dr. Thakkar is telling us, one of the important things, I think, for UHC, it really has to be, there are 2 things. One, it has to be evidence-based, and I'm sure that the government and all the stakeholders are really working very hard to make sure it's evidence-based. But you have to be able to communicate. How is this going to be rolled out? How is it going to reach all parts of the country to create equity, for example? And so that communication bit, I think, is very important, and the stakeholder engagement. but advocacy. So not just the professionals, not just the people sitting here, but making sure that you actually break this down to people in the media who have a wider reach, so that you actually are able to make clear what is going to happen in this whole program. But then also there are other issues, such as you need to define at the very early stage what is going to be the essential package for health that is covered by this UHC. I mean, for instance, something like a family planning, will it be there? Is it going to be, we know there is a big issue around reproductive health for young people. Are they going to be able to access this reproductive health and family planning services through the UHC? So that's very important. The other thing is, and this speaks a bit to the issues a colleague from Makueni was talking about, and part of the need to have the Cuban doctors in the country. As we are rolling out UHC, there should really be something, more work being done towards the health system strengthening. Because that's really key. There's no point really rolling out UHC if we don't have, and people will not benefit the same way if in Turkana we don't have a health system that can take care of that population the way it will take care of the population in Nairobi, the way it will take care of the population in Kisumu. We all know that there is a huge skew in the distribution of doctors in this country. Okay, so how are we going to address that in the UHC? And there's also debate about thinking about, and there's something that has been in the field of health for a long time, but we now seriously need to think, especially in this country, how are we going to balance our investments in curative medicine versus public health, preventive medicine. Because we want to prevent these issues before they get to the very expensive curative stage. Okay.
Yes.
But so I've been looking at the targets for UHC, and they also need to be realistic. We are talking about rolling right now, I think, estimating coverage of about 25 million or thereabouts in 2018, and talking about 100% coverage by 2022.
Yes.
Is this really realistic? And what are we learning from other countries that are rolling out UHC plans? For example, in South Africa, it's being rolled out over a phased period, over 15 years. So let us not, it can be exciting, it's a good cause, and I think generally people support it, but we don't want to get into a point where people get disappointed come 2022, and you're being scored on poorly because you set a target that is not reachable. Yeah.
All right. Yeah. So, we need to know also what are some of the permutations they've put in place for us to really realize that by 2022. It seems when they had the pronouncement of the Big Four, yes, there was that pronouncement, and maybe they went full steam ahead of the horse before putting down some of the actionable measures that we will actually put in place for us to realize this Big Four agendas, because there is no financing, there's only pronouncement. But when we come to financing, that is gray area that we need to explore this morning. So you raise a good question. Are we going to realize, of course, this ambitious goal by 2022? If we do not know, then what are some of the strategies that will take us there? Right? Let's hear from Professor Dominic.
Thank you, Debarl. This is an interesting discussion, and myself, from a healthcare provider's perspective, Dr. Onyango mentioned the issue of health systems strengthening. We cannot be able to deliver universal healthcare unless we pay attention to the entire healthcare ecosystem, and that includes the 6 tenets of health systems strengthening. One, we need to figure out financing. How are we going to finance this whole thing? The 25 million Kenyans, if we're going to do 100% of the population, how are we going to finance the entire system? Because you cannot do one. And when it comes to funding of healthcare, there are 4 ways that you can be able to do that. One, you do it through For example. 3.
Just to stretch, just this, stretch, come on. But very important.
If you don't consider the effectiveness of the delivery of care, then you're not going to deliver health. That's one. 2, the human resources for health. How are we preparing? And that's why I'm looking at this as an ecosystem. How are we going to deliver health care? We're not training enough people distributed across the entire country, such that the people in Ghana have the same access as the people in the next one is health information systems. How are we managing all the data that we have? Do we have enough data, for example? And Dr. Amit Thakkar is that's your area in terms of data collection. Do we have enough data? Do we have data in this country that tells us this region is as prone to certain diseases than others? Such that as we are putting resources together, we know what we are targeting. We'll talk about that a little bit later. The next one is leadership and governance. How are we managing the entire ecosystem of healthcare delivery, from the public healthcare system to the private healthcare system? How are we managing all that? And also from the national government and the county government. How is the coordination between the two? The next one is essential medical products and technologies. Are the people in Marsabit or Isiolo, do they have the same access to the same essential products and medicines that we do have in Nairobi and other counties? Then the next one is service delivery. How are we delivering the healthcare system that we think we are putting together? Now, when we look at the totality of the entire healthcare ecosystem, then we look at methodical planning on how we're going to strengthen our healthcare system so that there's access for healthcare to everybody. And healthcare, UHC does not imply coverage for everybody, because even other countries that have UHC, specialized medicine, they cannot be able to cover everybody. So then you have to determine 3 dimensions. 1, who is covered? Who are we covering? 2, what services are covered? And then 3, how much does it cost to be covered? So when you answer all these questions in an ecosystem kind of holistic view, then you'll be able to approach healthcare delivery in a more comprehensive manner.
Right, thank you. Let's hear from Lydia. Of course, when we're talking about health ecosystem, financing is a big component of that, and this is where also you come in, because insurance is very key. Out of pocket sometimes have actually led to a lot of people in this country, just going.
Where's the digital person?
Very providential when it comes to very serious illness. Let's hear from the challenges that also juxtaposing that with the national health insurance.
Just to stretch, just this, stretch, come on. But it's very important.
Panelists, not necessarily me, but even you too have questions. Some of the panelists also haven't had an opportunity to answer and ask those questions. But the challenges you face right now, let's begin from there.
From a private sector perspective, healthcare financing, most of the schemes or most of the access that people have had through private insurance. And a lot of people complain that, cost of private insurance is out of this world. And truthfully, unless you're in an employer-sponsored scheme, a lot of people will not take money and buy an insurance cover. Yet, when when the need arises, that's the time the family is considering whether we should be able to get a package, and are we able to buy a package that can take care of this cancer that has been diagnosed now, at which point it is already too late. And I think my colleagues here have talked about financing, and I think this whole universal health story needs to be looked at, from the whole spectrum, from providing basic care to those who have never really had, to also ensuring that those who go into private insurance are also able to pay for the expenses of this particular type of insurance. And so from a healthcare insurance perspective, we feel that, these two things have to work together. None is mutually exclusive. So you can't say that universal healthcare then takes away private healthcare. I think we've alluded to the fact that not everybody actually will end up having this kind of insurance. But we must find a model of financing that is going to enable more and more Kenyans be able to have healthcare. But I think also the issue of healthcare systems that we've talked about, and the Makueni example we've gotten to, from an employer perspective, for example, when they do buy private healthcare insurance, part of the problem is absenteeism, the fact that people are away from the office for so long, trying to go and find healthcare services all over the place. So for us, we are like, if then every county or every place in this country is going to be able to have doctors and services available, it means that people don't have to travel to the city center to get specialized care and stuff like that. And so we think that if all stakeholders engage and we walk this journey together, what we'll come up with at the end, I think, will be more beneficial to all Kenyans, be it from the basic healthcare all the way to those who opt to go for private insurance as well. Yes.
All right. And let's get down to brass tacks right now, because we had also Dr. Dominic Mwenje giving us all that list of where we need to explore within the health ecosystem, and we go to the government funding itself. And we have this robust, ambitious, of course, 3 trillion budget that was read by CS Rotich.
Right.
And right in there, I know there was also, this that was given to Wananchi through the Daily Nation. This is the budget, the Mwananchi guide to it. If you did have this was the 14th of June. And it actually breaks down where some of your taxes are going from the Big Four and the enablers of the Big Four as well. And looking at this, we see the health that is providing universal health coverage to guarantee quality and affordable health care to all Kenyans. 44.6 billion shillings has been actually set aside for this. Do you think this is a paltry amount because we've not been told if truly this is up to 20? Of course, this is for this financial year, but how is this also going to be doled out within the counties as well? You think there's a gray area on this? You think there's a target towards, is it broad just for the primary healthcare or the universal healthcare?
Right.
Let's hear from Dr. Amit on this.
Debarl, a brilliant question. And I think you've hit the nail on the head. The numbers don't add up for UHC. And we all know that. Is it a paltry amount? Yes. In fact, when the budget came out and you distributed this to the Wananchi,
yes,
it was clear that the amount of funds that we need for UHC to be rolled out for 47 counties, and what we've seen is an indication that the government commitment is minimal. Where did we change the course for healthcare in Kenya?
Yes.
We changed the course of healthcare in Kenya between December and January. When His Excellency announced the Big Four, his first announcement was affordable healthcare for all. That's what Bernard was talking about, that's what Dominic was talking about. That was strengthening the health systems in every county. That is what Dr. Andrew wants, that's what the guy in Turkana wants, that's what Lamu and Kisumu need. They want affordable healthcare for all. Somewhere along the road, we started talking about UHC. And it means different things to different people.
Diametrically different.
Totally.
Yes.
Diametrically different, where the energy being spent by most of the stakeholders and leaders is about coverage. How many people are covered, rather than how many people are accessing care. We need to change course for Kenyans again. Move away from coverage to care. What do I mean by this? If you look at the roadmap, currently they say 16 million Kenyans are covered, 36%. By 2022, we want 100% people covered onto a scheme known as NHIF. Are we serious about it? NHIF as an institution, we know what the gaps are. It's a completely weak state-owned enterprise. It's incapable of managing 36% of our population. Are we risking the lives of 100% of Kenyans onto a vehicle that is completely weak. Impossible. I think we should stop it. We should fix what we have right now. We should strengthen NHIF and allow diversity, as Bernard has mentioned. What do I mean by diversity? I think we should have choices. We should have people in different counties being able to choose different schemes depending on their affordability. County number 017, sitting next to me, they introduced a scheme at 500 shillings a year. NHIF, most cost-effective scheme is 500 shillings a month.
A month, yes.
Right? So you can imagine how many people in Makueni who were finding 6,000 so unaffordable are now happy that they belong to Makueni Care at 500 shillings a year. What this shows, there may be weaknesses. I'm sure the actuarial studies will show how Makueni can strengthen the scheme, maybe Kwale, maybe Nyeri. But what this shows that we must allow innovations in our counties to enable more Kenyans get coverage and care. If we restrict our Kenyans to only one institution, I think it's too risky, and we stand this danger of not providing adequate care and creating confusion. We need more innovation, more creativity, and that's the only way to provide UHC.
And of course,
even private sector, like Lydia said, should also coexist with county medical schemes, NHIF. But as a single payer, one system, I think it would be very dangerous for Kenyans to go that direction. 2.5 billion was allocated to pilot schemes for 4 counties.
Yes.
I'd like you to host another show where you only talk about
the realization
what is the progress.
Yes.
Bring all those 4 counties here. Ask them how is the money being spent and where is the progress, so that we have reality and honest feedback to the Kenyans on where the taxpayers' funds are being used.
And of course, Machakos is not here. Makueni, I think you should have gotten this chunk of money. Or you went full steam ahead with Universal, so there's no need, because all we do have is Kisumu, Nyeri, Isiolo, and Machakos counties. And these are actually the pilot counties that they will roll out the universal healthcare. And of course, we get to learn from them in terms of capacity. And it will inform also the rollout to other counties as well in subsequent years. But we want to take a short break right now. Then when we come back, of course, we drill deeper. Welcome back. You're watching In the Market here on AM Live. And I'm holding court this morning with Lydia Macharia, Director, Employer Benefits, Minet Kenya. Also, we have with us Dr. Amit Thakkar, Chairman, Kenya Healthcare Federation, also the founder of Avenue Health Care Center. We do have with us also Dr. Bernard Onyango. He is a knowledge translation scientist from African Institute for Development Policy. Also, we have with us Professor Dominic Mwenje, who is the CEO of Maternal Hospital. And we do have with us as well the CAC of Makueni County. This is Dr. Andrew Mulwa. Right, before we took a short break, we were on you, Andrew, to tell us more about how realistic NHIF is, and do you think, is it realistic and is it wise for Kenya to put all this tidy sum of money in one basket? What if we have issues of leadership and corporate governance? We've seen many corporations in this country going down the tubes as well. How will that be very critical in affecting, the populace when it comes to accessing affordable healthcare?
First, I want to agree with Amit that universal healthcare coverage is not equal to NHIF. And we recognize that NHIF as an institution has some issues to do with strength and even the capacity to reach, because when you want to achieve 100% coverage, it means the over 20 million households or thereabout needs to have insurance card. Does NHIF have the capacity to even deliver the physical card, even if they were given all the money, to deliver the physical card to every household within a year? Because cover is usually for a year. Suppose we got them all the money and gave them today, it would take up them probably 18 months to just issue the cards. So, and when you do not have the card, you are not covered, because essentially this is the document that you go identify. There are institutional gaps that must be strengthened. NHIF must be reorganized. And the other thing that I think is also critical is that to deliver UHC, there must be a component of compulsory contributions. that it cannot be left to the government to subsidize for populations, because once that happens, then sustainability is lost. You need a scheme that the people themselves contribute, and through that mechanism, you are able to identify the poor of the poor, the indigents who cannot afford, and those are the people that the government should target to subsidize. Does it have to be NHIF? No. The case of Makueni, for example, when we thought about starting a universal healthcare coverage, in fact, our first thinking, and for one full year, our thinking was around how do we work with NHIF and deliver this? Then it was towards the end of financial year, we realized we have not made a lot of progress. So we had to change our thinking and ask ourselves, is NHIF the only way we can deliver? So we identified what is our deliverable. We want to deliver affordable healthcare, cushion the population against out-of-pocket expenditure, so that when you seek services, you are not limited by the power of your pocketers at that time.
Yes.
And then it's when we ask ourselves fundamental questions. What is this that we need? Because we need to mobilize resources that we can guarantee that if I give you this card, when you come to my facility, you will get the services without paying, without being asked to pay. So we pulled resources. That's how we came up with the 500 shilling scheme. And is it working? Yes. It's 2 years down the line. This scheme has benefited the citizens of Makueni. When they are seeking help, they are not worried about the cost of treatment, because they are able to walk into our hospitals. They get services and use the card which they have prepaid to access the services, and the government is able to take care of the cost, the Makueni. So it is, the Makueni experience tells us that first, it is inexpensive to deliver universal healthcare. It is not necessarily an expensive endeavor. And number two, it is possible to have institutions other than NHIF that can be able to deliver NHIF. Then as a country, we need to have set the standards. What is the package that we need to deliver to Kenyans? And like primary healthcare in this country, when you go to public health dispensary or health center, services are free, but someone pays for these services. It is first, how do we reorganize the available resources?
Yes.
Just before this show, there was a clip on how we spend about 26,000 Kenya shillings to treat a single case of TB.
Yes.
If you look at the HIV program, we spend almost about the same amount. So we need to ask ourselves, how fast do we reorganize these resources? Because the same patient who has HIV has TB. Where can we get synergy? So that instead of using 46,000, we use 30,000 to treat this patient, which has a common. So by so doing, we will have saved 16,000 for every patient. That we first and have an effective mechanism of delivery to achieve maximum quality and at minimum cost.
So when you say that UHC to achieve it is expensive, from what perspective are you looking at?
I am looking at it from what Makueni is doing, for example. We are not the county with the highest percentage of health budget. Many more counties have bigger health budgets than Makueni. But using the little resources that we have, we are able to reorganize our finances so that we are able to deliver universal healthcare in the Makueni context to the citizens of Makueni within Makueni without them having to pay out of pocket. So that is what I mean, that it is not necessarily something that you should talk about. When you talk universal healthcare, you don't necessarily have to talk about 100 billion or trillion. It is first the resources that you have ask yourself, what efficiencies can I have so that I am able to utilize the resources that I have?
Dr. Bernard, do you hold with this view? Because he thinks that, not spending out of pocket and people now accessing finances, that is actually universal healthcare. But in the larger aspect of universal healthcare, it is not just about the affordability. Also, we are talking about the accessibility. And we're talking about quality. Exactly. And achieving that, given to also what we have in the standard today, look at what we have, where the CBK governor is saying that, yes, it is impossible for us actually to realize the benefit also of SGR. If we just look at that, we have exceeded borrowing limits, says CBK boss. The big infrastructure projects are not yielding fast returns to repay loans. Infrastructure is critical for us to achieve UHC. That's the question I'm asking, because it seems maybe we have one aspect of the universal healthcare, which this Dr. Mulwa is talking about, affordability. What about accessibility? What about quality? Yeah, I might access this particular facility, but we have incompetent, staff members. We have also archaic equipment in the facility as well. Maybe you can enlighten us on that.
So I think that's critical. So it's like he said, it's the ecosystem. You have to look at
its entirety,
in its totality, all these aspects. I mean, when you talk about the Cuban doctors, and I know there's a lot of debate whether it's a good thing or a bad thing.
Yes.
But for instance, I talked about the skew in distribution of medical professionals. Mm-hmm. What is it that is keeping our medical professionals from staying in Garissa, from working in Garissa, from working in Turkana, from working in Lamu, for instance? Why does everybody want to be in Nairobi?
Yes.
Those are issues you have to address. Part of it is, I mean, what you're saying, if someone is a doctor, yes, you really want to give service to the people, but at the same time you're also thinking about your own quality of life. Okay, so when the doctors are complaining that you're now giving, for instance, the Cuban doctors housing and other add-on packages, it could be, it could be that people could debate around it, but I think what people need to find out is, why is it that we have this skewed distribution of services? Mm-hmm. The other thing, like you're talking about, what do we know about capacities within the counties? And people have talked about capacity within the counties. It's a concern, but is it being addressed effectively? Is it data driven about how we address these concerns? So that's another bit. But even talking, I think one of the things, when people are thinking about UHC, that sort of strikes me, and I alluded to this earlier, this mix between preventive and curative care. Mm-hmm. It seems to me that there's a lot of focus on the curative part, but we really need to, this country seriously needs to invest in public health. Because at the end of the day, by the time people get to that hospital, that clinic, that cost is much higher than if, for instance, we are able to strengthen our public health services, such that, for instance, these things we are seeing in the news and we don't know about whether the food we eat is good or not, and we don't know whether the mboga you're eating is good or not, and we know that increasingly, if you look at the Ministry of Health strategic plan, we already know that the NCDs are going to, over the next 10, 15 years, probably they're going to far outweigh the burden in hospital. We are going to have more people going to hospital because of NCDs than infectious diseases. And we know that some of these things are really NCDs. If you really think about investing in public health, think about, people we should be thinking about what nutrition. Nutrition is not high on our list of priorities as such, yet it's such an important it's such an important bit of health which have even consequences for cognitive abilities, because if you don't get your nutrition, the first 1,000 days are critical to get proper nutrition, and it have lifelong consequences. This is evidence-based. So I think what really both the national government and the county government should do is to really get back and rely a bit more on evidence, and also for evaluation. I mean, Dr. Thakkar just told us here we had we have a pilot for this UHC. What is emerging out of that pilot? What are the issues, and why should all stakeholders should have this information available, so that, because it's not about one person or one section of the society having all the solutions. It's really about all the stakeholders here, the government, researchers, Camry, everybody coming to the table. Let's see what's the evidence, and let's get solutions together. And let's make the information available to Debarl and his colleagues, so that they communicate the right information to the people, so that people are not sure whether, is this going to be beneficial or not. But Debarl and his colleagues should not be debating this in a vacuum. They should be debating this based on evidence.
Thank you. And of course, you alluded to the fact that there's a wide berth of data. And we wonder how, when it comes also to healthcare, where do we draw the data so that we can make informed decisions? Do we have a good repository of data in this country? Because where we can see people drawing data is maybe from pharmaceutical firms as well, right? We can see people going and saying, okay, these medicines, there's this locality in the country that actually a lot of this type of medicine is going to. So we have maybe this trying to cure this particular disease. When it comes to data, which is very key, and I like what also Dr. Thakkar alluded to, the fact that I want us to just make it clear. Why was it morphed to, first it was affordable healthcare, then again now it morphed to UHC, universal healthcare, and what he says there's a wide berth of difference. And this is a big topic also when we come to Europe right now, when people are talking about immigration and refugees, right? Because the dynamics between the two words are diametrically different, and the repercussions are great. So was there an informed decision why to change from universal healthcare or affordable healthcare to universal healthcare?
Debarl, I think when this whole discussion started with the Big Four, the language was on affordable healthcare. Somehow along the way it morphed up to universal healthcare.
Is there any rhyme or reason for this?
I have no idea how this morphing took place, but there are repercussions in terms of affordability. That's one. There are also, if you look at the 6 tenets that I was talking about, all have to do with strengthening the system that's delivering healthcare. And I think we also need to understand what is the end goal of universal healthcare. One, it's providing financial risk protection to the population in case they get sick. 2, improved access to health services. 3, improved health outcomes. And when we look at those 3, so we are looking at both preventative and curative medicine. But we seem to focus more on the curative than the preventative medicine, which is also very, very expensive. And I think that's what Dr. Onyango was alluding to. Now, when it comes to where we are now as a provider of healthcare services at Mata Misericordia Hospital, we have to deal with 2 constituents, actually 3 of the 4 in terms of funding. Remember I said we have 4 in terms of funding. We have the government budget, which we don't, as a private institution, we don't access. But we have NHIF, which could take the compulsory part that Dr. Mulwa was talking about. Then the voluntary health system services, and the out-of-pocket. The issue we have, and if you talk to anyone who runs a hospital in this country, will tell you, this will stand in the way of delivering healthcare, is the insurances, NHIF and everybody else combined. If you go to any hospital, the cash flow for a hospital, which you need to run the hospital, is skewed 80% towards insurances and 20% towards cash. Now, the biggest problem with that now becomes when you're collecting 20% cash and 80% is insurance, and insurances are taking 180 days to pay for the healthcare. Then you start to see now, as much as we also want to play a part in the delivery of universal healthcare, it also becomes restraining on us because the insurances are not paying enough. And some of them, it's actually a game. You have insurances that owe you 100 million shillings. And then when you complain, they send you a check of 20 million. But they don't tell you which patients they are paying for. That means I have...
So it's a headache for you, actually.
Absolutely.
Yes.
So I have to have full-time staff that I have to go through all the patients who, under this insurance company, over the last, some of them 365 days old, others 180 days old. And we have to figure out now, how do we get these 20 million to pay for the 100 million of services already, already delivered. And by the time you finish the reconciliation, which is almost impossible, they have already incurred another 30 million or 40 million with the same insurance company. So it becomes a big problem as more and more of our people access the insurances for the hospitals to actually run properly. At this time, if you talk to most private doctors, a lot of them actually stopped taking insurances. Because the payments are so poorly done that it limits, it holds your, I call it you're held in a strategic straitjacket. Your hands are tied. The revenue generation is there, but the revenue that you're getting, the cash flow you're getting for the insurances, and that's a big challenge. And as we get more and more people now into NHIF, the very same system that wants to make sure that we have universal health care is the very same system that is going to make sure that those who are delivering care are actually not able to deliver care because the payment is so bad. Right. So we have to look at those from that perspective.
Can you have Linda actually to just clarify on this? Why the circle back, there's a slow uptake on that? 180 million shillings, a salty 20 million shillings is just paid in lump sum, you know, and then they have the headache of actually now trying to allocate that. Why the circle back, we have a long transition time to do that?
Yeah, okay, I think what I would say on that is that there is, there has been in existence, standard agreement in the industry that, there's 90 days credit, they have 90 days within which to actually bring us the bill, then we have another 30 days within which to process this bill and actually pay them. And it is true, I agree with him that there are times when, there'll be these big discrepancies between what the insurer is paying and what the hospital is expecting. But to me, I don't think it's a critical problem. I think what we need to do is to sit as stakeholders, and I think that's what the Healthcare Federation that Dr. Amit is heading right now is trying to do, where there is a conversation on how do we more effectively pay for what it is that the hospitals have actually already delivered to our clients. And this thing has many players. There's the sponsor, then there's the user, then there's the provider of the service, and then there's the person like ourselves who's the provider of insurance. And until there is a good conversation between those four parties, everybody feels injured. In the same way, like he talks about payment, for example, and delivery, delay in payment. For us, as the persons giving out insurance and all that, there's also the element of feeling that there is over-servicing, there is overusing. So if you have some of the facilities, if you have, say, a radiology machine, suddenly everybody who walks through that door, needs to be charged for, to use the radiology machine. So I think the devil is truly in the detail. And those who have maybe managed to have a consistent or conversation between themselves and the providers of service and to work through the reconciliations have been able to find a working rhythm that sort of works. But yes, I think there is a need to review those 90 days and 30 days and see, can we reduce the window so that as the service is given and the payment can come as quickly as possible. And if you look at the more developed markets, I think they have come up with a system where things are done online and they're done real time sort of, so that the payment period can be reduced,
shortened,
so that we can be able to enable the healthcare providers to continually give this service without suffering from a cash flow perspective.
Stakeholders engagement crisis, this is what Dr. Amit, you are alluding to. Is this now the stakeholders engagement crisis that you're talking about? Right? Maybe you can try and
I think Lydia and Dominic have hit the point really home. And I think when we talk about UHC, we talk about stakeholder engagement, we often talk about PPPs. And Bernard has alluded to in his studies quite a bit of. But we have a new PPP for UHC. PPP stands for public-private partnership. But the PPP for UHC that we need to embark on immediately is, the first P stands for partnerships. That's stakeholder engagement. Like Bernard was saying, that we need to involve everyone. Ministry of Health, NHI should have turned up today. But I'm glad what NTV is doing and the media houses are doing. You are also a partner.
Yes.
So we need to increase partnership with the counties. The partnership in health system is weak. If we don't strengthen it, we'll have a problem. So that's our first P. The second P is preventive healthcare, which focuses on primary healthcare and looking at quality centers all across the county. That's non-negotiable. It starts right from level 1, making community health volunteers into community health workers, strengthening clinics so that we keep people healthy at the homestead rather than waiting for them to be treated at the hospital doorstep. So that's our second P.
Yes.
And the third P, which I really want to emphasize here with you, Debarl, today, is poor. Poor should be our priority.
Poor.
Every decision that's being made in the budget, what I see in the ministries, at high-level discussions, seems to be forgetting the poor, including when we have people being sent to India for treatment and payment, including high-level equipment being put in for oncology. Who is that for? When you don't even have anti-malarials available for children who are suffering from malaria in their counties. We have a misplaced priority when it comes to allocation of tax and funding. So clearly, we need to put poor on our map first before looking after the rich. NHIF is looking only after the rich. So let's find another system that looks after the poor. Let's focus on the poor first before we put all our tax money looking after those who already have a cover. So I think that the triple P for UHC are those 3 Ps that we need to start working on as team members right away. Otherwise, we stand the danger of collapsing the health system even further by 2022.
Right. And I like also what you said recently, that the biggest disease affecting healthcare in Africa is poverty.
Correct.
Right? That in Kenya, only 6.1 million people have healthcare cover. This sad reality implies that most Kenyans will have to dig deep in their pockets to get access to healthcare. Most families across the country line, across the poverty line, I should say, as households have to cater for the very often costly medical expenses. The biggest disease affecting healthcare in Africa is poverty. And of course, you're giving a keynote speech there at Strathmore Business School as well. So the poor. And this also drew my attention yesterday, that it was on the front page of the Daily Nation. And maternity healthcare. We know also there's a Linda Mama program that has been rolled out by the NHIF as well. You'll tell us on the ground what is really happening with the Linda Mama program, but let's just take a quick look at what was there yesterday on the front page of the, especially when it comes to maternal healthcare in the country as well, on the front page of a Business Daily. If we may, please. Yes, it now costs 200,000 shillings to deliver in private hospitals. And my attention was actually on how, maybe you can tell us, you are a CEO of Mater Hospital. We have Dr. Amit as well from Avenue Healthcare. Hospitals link surge in cost to new taxes on medical equipment and workers' quest for higher wages, new taxes. Then, Dr. Mwenje, you're here as well. On top of a list of, actually, is you, right? We have 2016 and 2018. There's a spike of 20,000 shillings, and this is a childcare cost, and this was cesarean section, isn't it? Right? And we have MP share going down, 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 down. Avenue Hospital, you're here. Avenue also, you can tell us also that particular spike as well, what really is informing that, right? And Nairobi Women's as well, medical, it goes down, 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 down. And the Linda Mama program, which is meant to be free, but the facilities are wanting. Let's just begin from Mata. This information, a cesarean section is becoming, because most people complain about the cesarean section in the country, that you go to these private hospitals, then they're quick off the mark to take you to cesarean section, while you can actually just have a normal delivery, right? So this has been mostly, and the people say now they're colluding with Lydia in the insurance industry, right? Now they'll say, okay, yes, you have insurance cover. Oh, fantastic. You are complications, delayed, labor pangs are taking a while. You need to go for the C-section. Explain for us, when we have this, how can our poor mothers access your facilities if this is skyrocketing like this? And sometimes when you actually come with your card, they'll have to consult the insurance. Then they'll say, we can't pay the full amount, 220, maybe half of it, then the rest is out of pocket. So it doesn't make any leak of sense if you have insurance and we don't get the information why you don't cover fully.
Let me start by saying that at Mata, we do C-sections when it is absolutely necessary. We don't do C-sections because we are driven by the revenues that are coming from the C-section. Is when the doctors feel that the mother or the baby is at risk and this needs to be done. Now, on top of that, we've had the labor costs the last 4 years. 4 years have actually gone quite high. You remember when we had the national strike with the healthcare workers? I think Daktari was probably practicing at that time. And what that does, you see, with the private hospitals and the faith-based hospital like ourselves, we don't have government support, which means every cost that we have to incur has to be borne by somebody. That goes now to the insurance companies, also to the private patients and all that. And because we don't have government support, we may seem as if the cost is actually higher. If you go to the public hospitals and they have to cost everything that they do, you would see the same numbers, except they're funded and they're backed up by government. So to be very clear, we don't do C-sections when it's not necessary. Also, we have had an increase in taxes in equipment, and I think that's true as you bring the equipment. But the cost of labor over the last few years has significantly gone up. And because of that, the procedures also have to be a little bit more expensive when it comes to, and that's for us it's 20,000 in the last 2 years, and when you consider what you're paying the specialists, the nurses, the entire team that is in that theater, you see the hospital is left with a very small amount of money, because most of that will go towards the team that is taking care of the mother and the patient. And here you have two people that you're taking care of. You have a team that's taking care of the mother. You have another team that's taking care of the baby. So it is an expensive procedure, but we don't do that at Mata because of money. We do that to make sure that the mother and the child are safe.
All right, let's hear from Dr. Mulwa. So we have this Linda Mama Boresha Jamii, which is meant to actually come in and for people who cannot now afford the private sector. We want to see how realistic has it been so far, because we know also bed capacity in some of this public hospital has been a key issue. And if you've not really signed up for this Linda Mama program, yes, NHIF is providing this. If you may just take a full cover of this so that they may see this particular expanded program for free maternity package benefit, and hashtag 263 or star 263 hash is how you can join by dialing that. And there are good benefits that we do have there as well. Accessing eligibility is all pregnant women who are Kenyan citizens are eligible to be members of free maternal services. Let me try and zoom out a bit so that you can see it clearly. And it says also access points for registration, mobile phone, NHIF registration portal, contracted healthcare providers, NHIF services centers, Huduma centers countrywide, and it goes on and on. You can head over to their website. You can actually get all this particular brochure for you to know the details about the free maternity. The realization of this, yes, we have it free, but we were talking about the quality, we are talking about the accessibility. So what has been the challenge of NHIF with this particular Linda Mama program so far?
I think I will speak on Linda Mama in the context of the President's Declaration of Free Maternity Services from 2013, which prior to July 2017, county governments were delivering free maternity services to all pregnant mothers, and we would get reimbursement directly from the Ministry of Health. And as a matter of fact, in 2017, there was a need that for transitioning so that NHIF would come on board, so that expectant mothers do not just seek services from the public health sector, but they are also able to seek from private and mission facilities, which was a very noble idea. What has happened in the last 1 year is there has been first a slowdown in absorption because it's easy to say registration is mobile, and this information to the service providers, especially in the rural areas, it has actually for the first time in the last 1 year, we've had mothers come to health facilities and they are not ready, and by the time they get into the Linda Mama program, they have already delivered, and some in some circumstances, and we have had a national conversation on this, have been retained in hospitals for lack of finances.
Yes.
But while those are system efficiencies that we are addressing to, I think the program is noble. But because I was in Makueni when skilled birth delivery was 19%. Only 19% of mothers would deliver in health facilities. Courtesy of the free maternity services and Linda Mama and improvement in service delivery in terms of infrastructure, human resource, we are now talking about 60% of mothers delivering facilities, which is 3-fold increase in the numbers. But yes, there are also issues that we have as counties with Linda Mama, that if a mother delivers in a private health facility, I think their rebate is 17,000 for normal deliveries. While in the county referral hospital or county hospitals is 5,000 for hospitals, and for the dispensaries and health centers is 2,500. This disparity and actually now speaks to what is you are projecting on the cost of treatment. That, and he rightly mentioned that the inputs that the private sector puts in to conduct a cesarean section, for example. Look at the wage bill, for example.
Yes.
In the last 1 year alone, there has been 40% increase in wage bill in terms of the pay for a doctor, for clinical officer, for nurse. And you know you have to be competitive. Otherwise, when an advert runs elsewhere, or you are working. So, and you want that to continue. So, this addresses those issues. There is fast. Compare both private and public. They are comparable. So we need first look at it. And I think for the fees and charges, there has been attempt by the medical board to give rates at which the doctors can charge for various services. But now we need to go further and granulate. What is the cost of gloves? How many gloves is the number? So that we actually have some data that tells us this is the cost of delivering service. So,
thank you.
So that when we say we are providing free services, we must be able, or subsidized services like Linda Mama, we must be able to say, Linda Mama,
thank you,
takes this much.
Right.
And to deliver this service costs this much.
Right. And looking at that list, Avenue had a list at 165. And we know how impassioned that you You studied a journey in 1995. You bought a van, you converted it to a mobile clinic because you saw the poverty. And of course, even looking at that listing, it was at 165. Were you facing the same challenges that you had to reconfigure? Tell us more about this. And where then can we get this PPP and have also the hybrid sort of systems, yeah, of financing?
Yeah, thank you for supporting me during the early days, during the van
Yes.
and the train that we took to different parts of Kenya with NTV, thanks. But I agree with Andrew, the wage bill is the one that takes a lot. 65% of surgical costs in any private facility is the surgeon and the anesthetist.
Yes.
So from that piece, you can take 65%, 70%, it goes to about 80, 90,000 for the gynecologist who charges. It's the normal charge they charge every private facility, all the ones you listed there.
Yes.
And then the anesthetist takes a 1/3 of that. So 90 and 30, you'll easily get 120 to 130 just going to the doctor's fees. And then there's the supplies. We've tried to keep everything low as possible. Keep a margin and make private sector sustainable, because remember, we don't get any budget support from the treasury. We have to earn money from either the insurance companies or cash pay, pay our health workers and sustain ourselves. But the inputs for healthcare in this country are very expensive. Do you know every medicine we bring in is mainly imported? Every equipment that we have in this country is imported. We don't even have a single manufacturing medical device company. So all these global inputs that come to the private sector is what we pass on to the patient.
Yes.
Imagine VAT was introduced on medical equipment, which was never there. So for every ultrasound we buy or a CT scan we buy, we are paying 16% VAT. Where does that cost go to? It obviously gets transferred to the patient. So we are talking to the government saying that do not increase licensing, duties and VAT costs to the health sector, because as you do that, all this money gets transferred to the patient. Let's remove all unnecessary taxes in the health sector if we are going to achieve UHC, as well as the private sector plays its role in participating in promoting affordable healthcare.
All right. And maybe a clarification, because we have also callers and tweets that we have to read and hear from our callers as well. Linda, tell us more about you know, that particular figure that we do have. My director tells me I should pick up the call, then we'll come to you. Let's just hear from Arthur, who's calling from Mathare this morning. Arthur, good morning.
Good morning, Debarl.
Morning to you. You have a question or contribution from our panelists?
Yes, I only have 2 comments.
Yes, please.
One, I think we need to make healthcare a very fundamental issue in our country, because
yes, please.
The privatization of healthcare has really caused us, especially people from Mathare. Hata nizungumze na Kiswahili kidogo.
Asante.
Watu wa Mathare hawawezi kulipa hizi private hospital. Na ziko very expensive. Na unapata daktari anafanya private hospital na anafanya public hospital. Inafanya daktari anapata pesa nyingi bure, lakini hahudumiwa Kenya. Jambo la pili, unapata hii insurance inatakiwa iwekwe ina category that watu wa Kenya wa chini wanaweza kulipia. Isikue wengine wanashindwa kulipa. La mwisho kabisa, Debarl, ambayo ningependa kuomba tafadhali. Jambo la healthcare kwa watu wa Mathare na watu wa mashinani ni jambo ngumu sana. Tunakufa, wengine wanakufa Kenyatta, wengine wanafanyiwa amputation Kenyatta. Kama mimi nimevunjika mguu, Debarl, nilikaa Kenyatta 6 months. Karibu mguu yangu ikatwe. Ikanibidi nimechukuliwa na daktari nikapelekwa private nikaweza kusaidika. Mpaka saizi I'm on still on crutches. Lakini sijapona. So it is a very big issue. Ukiingia Kenyatta 6th floor is when you will know that Kenyans are dying and Kenyans are suffering because they cannot afford the doctors who are working in private, and also they are also working in the public hospital. Unapata daktari anakuja asubuhi Kenyatta saa 12 anafanya ward round na students, by saa 5 ametoka ameenda private. So unapata kuna challenge, kuna matibabu. Hata watu wanaenda mara 2 kwa wiki. Then unapata private hospital kwenda kuona tu daktari. Hii watu ambao wamejiita madaktari ni ya call, si biashara. Let them turn it to a call, not a business.
Thank you.
Wafanyie watu huduma. Hata kama wanapata mshahara kidogo, lakini iweze kuwa ni huduma ya kusaidia wananchi.
Asante. I think others have spoken for many Kenyans this morning. Also, we do have D. Warira. She says, yes, NHF is not equal to universal health coverage, considering our years, our health, I should say, has been in the trenches for years. Government delivering 100% UHC by 2022 is a pipe dream. And of course, we do have also that question mark for a country that is not used to make decisions based on data. We are a long way from realization of universal healthcare. It's good you made them know it's a system, not just a linear thought that enrolling to NHIF and pumping money is universal healthcare. Also, we have George says Lydia Macharia's observation is right. We have also Masi Nyambura saying Cuba has a robust and modern healthcare system. Thus, in my opinion, we should have absorbed their system other than bring in their doctors at an exorbitant cost, other than language, lack of modern equipment, and understaffed hospitals will also pose a challenge. We have member M. James, she's saying, or he's saying, specialists that we don't teach in our medical schools. Oh, shucks, I didn't see that. All right, I'll gloss over that. Also, we have Bo Buddha saying, why call it universal if you have basic, premium, and executive packages? How do you define who qualifies for what package? What does evidence-based mean? Many questions there. Our panelists are here. Finally, let me just read this, Bonner Director, the last one. Primary healthcare, MCH, FP, TBS, CBD, and now universal healthcare. The medical ecosystem has been mapped many times. No mysteries there. Dust off the myriad reports and assessments moldering in the Ministry of Health, filing cabinets, synthesize recommendations and start implementing. This is what Andrew J. Franklin is saying. Right, let's just comment on this, but I'll be remiss if I don't come back to you because we have short time to actually wind up. Lydia, to tell us, we had those figures. If my director may just pick up again on those figures that we had. But when it comes to insurance, you don't go the full orbits and tell us this is 220. They'll always say, no, we have to consult our insurers, all right, farm, and they'll advise. Then we find it is 220, you'll give 110. Okay. What informs that decision?
All right. I think there are very many different scenarios that play out. But I think the first thing is member education, understanding the policy that you have purchased. So you may have purchased a maternity package that offers, say, 100,000 yes. Kenya shillings or 150,000 Kenya shillings, but that's for a year. So in between your, there's prenatal, there's postnatal, you've been using this particular cover. Okay. And so by the time you come to delivery, perhaps what is available for you is 100,000. And so at that point, when the hospitals get in touch with the insurance, the hospital says, has to find out how much are you willing to pay. Like he said, there is what insurance will pay, and the rest, if there is an out-of-pocket, the member would have to meet that particular expense. So it's not that, you have purchased 220 and the insurance wants to pay 100. There is a whole spectrum of other services that go on in the year. And that might be what would cause there to be, at the time of delivery, a smaller portion of your benefit. So it depends really on what it is that you have actually purchased. But really to comment on the cost of, say, maternity delivery at the hospitals, I also think that the cost of care over and above the cost of implements and all that is also driven by consumers. You see, the consumers today, I think the Makueni colleague spoke about the fact that people used to give birth at home and, people didn't really go for high-end hospitals for delivery and all that. But we do have a generation that is averse to normal delivery that costs much less than the cesarean section. Many of the young ladies just don't want to go through that. Oh, really? And there is the discussion that they have with the doctors that I don't want to have a normal delivery. I want to go for a C-section. Now, that is called elective. It's a choice. Yes, yeah. You pay. If I want to buy, a brand, say, I don't know if I should say this, but a car, you can choose between a regular brand or a high-end brand, and the cost of those are very different. So yes, I think the whole Arthur, whose first comment we read, has steered us back to the real conversation, is that there is a need to streamline even delivery of care in our country as we talk about universal health care. And I think what I would say is that we just need to get down to the basics of actually looking at how do we deliver affordable health care to all, right? And then there will be choice. If I want to go and give birth in one of these particular hospitals, then I must pay for it. I should not expect the system and other people to pay for it. But there should at least be basic care that I can access if I don't want to make the choice to go to a private.
So that is purely elective.
Yes.
Right. We're winding up, and because of time, I just want to apportion also your headline thoughts, because we've discussed largely on financing, right? I would love also, Bernard, to just briefly, in maybe 30 seconds, to just tell us about the health information system and the data collection, which is we don't have a good repository in this country of data where we can make informed decisions. Then we can have you also talk about governance and leadership, Dr. Dominic, as we're winding up. And of course, we can also talk to Dr. Alfred. We are winding up on Alfred Mulwa to tell us more about voluntary health insurance. What is it all about? Dr. Amit, you can tell us more about, as we're winding up as well, what is the way forward with the partnership and the hybrid system that we're talking about? And finally, why should we have also, what are some of the successes we can hail so far as we're winding up from also the insurance with the NHIF and the government partnership? Briefly, let's hear from...
Yeah, I mean, that's great, because a health information system is really critical, because it's going to be, I think one of the comments for Twitter have been, you know, we have all the policies, we have recommendations, can we implement? But even as we're implementing, we need to have the information that guides us also in monitoring and evaluation, knowing what the needs are, exactly what the needs are. And there is a health information system. It may not be the government, the national government have a health information system that draws all the way from the grassroots, but maybe perhaps it should be made more robust, and we have worked in the past with Ministry of Health to see how we can put in more indicators that will inform implementation of programs better.
Thank you very much. Dominic, Professor Dominic, 30 seconds.
Yeah, very quickly, just on what he's talking about before I jump to the other one. Just give me another 5 seconds.
Will you do it on 30 seconds? We're stuck for time.
Yeah, but about 30 seconds.
I'll stop you midway.
On the data. And this is something that we need to start emphasizing in this country. We are not doing enough drug trials in this country, and that's an issue. As I was discussing with some other people, the drugs that we use are tested in Europe, in India, and other countries, but we are not doing enough of that in this country, and therefore sometimes because the genes are not, the genome gene makeup is not necessarily the same for everybody else.
Thank you.
That's data we need to start collecting.
Thank you. 30 seconds are over.
30 seconds now on the PPP. On the PPP, and I'll tell you what matter we are doing on the PPP that Dr. Hamid was talking about. That's now governance leadership. We can take these programs like we have a Matterhatran, where we focus on the poor. AIDS program, we focus on the poor, and by doing so, we are also complementing the government in the ways that should be doing in providing.
Thank you. Right, let's hear from Dr. Mulwa briefly, 30 seconds.
I think the question of voluntary health insurance was described earlier, and I had also mentioned that for Kenya so that everyone is not left behind, there is value for making a basic compulsory health insurance.
Thank you.
So that which has benefits that are defined, so that every Kenyan can be able to access.
Dr. Amit,
briefly. Make the best call. Make health a fundamental issue. We need to move from talk to action. The only way to UHC is through a mixed model where there's a role for the national government, there's a role for the county government, and there's a role for the private sector. That effective balance is the secret to UHC 2022.
Right. Lydia, finally, headline thoughts?
I think I also agree with Dr. Thakkar that Arthur did actually give the best contribution, I think, out of all. And our view is that we need to go back a few steps and make this vision clear. What do we want to achieve with universal healthcare? Look at how will we achieve it? How do we go about it? How then will it be financed? But more so, we also talked about the issues around why do we even get sick? So that conversation needs to come into this particular discussion, because the things that are affecting Kenyans are things like diarrhea and URTI. They don't need large machines. We just need to change the way we live a little bit. And then we appreciate what has been done so far.
Thank you.
But we believe that if this conversation is driven correctly, it will benefit very many more Kenyans.
Right, thank you.